Prepare to experience the strongest radio allowable by law. Secrets will be revealed. Myths dispelled. From the studio gym where excuses never apply, it's Super Huma Radio with your host, Carl Lenore.
I know you're asking yourself, I thought you weren't going to do Superhuman Radio anymore, Carl. And that's true. Eventually I will stop completely. But I still have some good shows up my sleeve that I feel committed to do. Today is one of them. Because as being one of the forerunners to talk about peptides, me and Anthony Roberts back in 2006 talking about recombinant IGF and then GHRP6 and so on. We really led the way. There's some guys and gals in the bleeding edge of peptides who will admit that they first heard about them on my show. And I'm very proud of that. And we will keep up that tradition because peptides, as opposed to pharmaceutical drugs, are messages between cells that tell cells how to fix themselves. And I want to make this one caveat before we talk about this. Peptides will never make up for a shitty lifestyle, a horrible diet, or the horrible things that you do to yourself. A lot of people are left down. I continue to get emails from people. Well, what peptides are good for liver problems? Well, there may not be one. Maybe you need to find out what liver problem you have and address the insult and get that out of your life. Then peptides can help you fix things. But that's the only caveat I would say. Peptides are magic. And as you may know, the FDA has done its best job to squash the ability for people to get them because pharmaceutical companies don't like us fixing our problems. They want us to take a drug for the rest of our lives. But we know all that. Before we get started, I have to thank my only sponsor, and that is Legendary Foods, makers of the sweet roll. If you like Cinnabon, but you know you shouldn't eat it, here's your alternative. These are cinnamon, chocolate, and wild berry. They 20 grams of high-quality dairy protein, 5 net carbs, less than 1 gram of sugar. And, of course, the tasty pastry that started it all. I still love them. You know, I'm one of those people that has a sweet tooth, and I just don't feel like my meal is done unless I have something sweet. And I love these. I love the strawberry, and I love the blueberry. They're out of this world. And I don't feel like I'm getting out of my nutritional lane. Go to shrnetwork.biz/legendary. Use the code SHR10 to save 10% off. But more importantly, to let them know that you heard about them on Superhuman Radio. We ended the show supposedly in November of last year, which made me exactly 18 years in this space. And we will continue to do periodic shows. So stay tuned for that. Now I'm going to bring my guest on, who's a friend of the show, a longtime educator, and that is Dr. Suanne Ferree. How you doing, Suanne?
I'm doing great, Carl. So good to see you.
Yeah, right. It's good to be seen. You know, I'm 65 years old. I've weathered a stroke. And I keep on chugging along.
How did you come out with that? So great, it looks like.
I was in the gym the 3 days after I was hospitalized.
That's perfect. Of course you did.
And I told the story. I just took a bolus shot of thymosin beta-4, and in the ambulance on the way, because I was completely paralyzed on the left side of my body. I was drooling. I couldn't talk. And all of a sudden I moved my arm, and the guy goes, "Oh, no, you must have had a TIA." But when I got to the hospital and they did the MRI, they said it was ischemic and hemorrhagic. There was blood around. But I didn't say anything to the doctors of what I did. I just kept my mouth shut. They all said, "Do you believe in God?" I said, "Sure." "Well, you need to thank God because most people with that kind of stroke are here for a couple months learning how to walk again." I
Yeah,
just,
that's
I didn't
awesome.
say anything. I didn't say anything. Anyway, so let's talk about, since we're teasing here about peptides and their value. This is a great book because I think the number one reason that people want to know about peptides is, what can I do to reverse the aging of my body? Do you find that to be true?
Absolutely. I have so many patients that come in with that exact concern. They're doing something really great. These are world changer kind of people who are coming in and they're saying, how do I make sure I can keep doing this awesome thing that I'm doing, that I'm really excited and passionate about well into my older age? I mean, I think about you first doing this show and now with your new venture, it's very exciting. You want to not stop doing this great thing that you're doing. And you and Elisa with your great romance, you want to not stop being part of that. So how do I keep being part of that? How do I keep showing up at the gym? How do I keep showing up in business with my family and keeping my body going?
But just your opinion of what I said at the beginning of the show, my preamble, that you have to make sure that your house is tidy before you start introducing peptides. How do you, when people come to you and I've heard about these amazing things with peptides, do you have that discussion with them? Is it sobering? Does this disappoint them?
Absolutely. And this is a big focus. I probably repeat this 10 times in the book. They work really great if you're already doing all the things to help. So we can use this, the more familiar peptide that everyone's familiar with, the semaglutide, and just say, you're going to probably lose some weight, but you're going to lose muscle mass if you're using that without doing the whole program. So people will come to us and say, why is your peptide so much more expensive than it is? I can walk down the street to Joe's weight loss shack and I can get it for whatever cost. Well, it's because we have a whole program. You're going to actually get some nutrition counseling. We're going to look into your intestinal health. We're going to make sure you're getting adequate protein in your diet. We're going to make sure you're doing resistance exercise. Because all of those are really important. And if you're not doing those things, if you're drinking a glass of wine every single night or 5 glasses of wine every single night, you're not going to be able to lose weight. And in fact, you're going to end up hurting yourself because you're going to end up with the muscle mass, with sarcopenia, and being a fat, skinny person.
And women need to understand, and I know your book is focused towards women, which is important in my humble opinion, but women need to understand that muscle influences bone mineral density.
Absolutely. And there's so many of these, a lot of the peptides we use are anabolic peptides. And when I say that, I don't mean in a, for example, oxytocin, which people are mostly familiar with because of pregnancy. This is one of my favorite anabolic peptides. And when I say anabolic, I mean it's not causing breakdown. Things like thyroid hormone cause breakdown, cortisol causes breakdown, but things like estrogen, testosterone, and oxytocin, along with others, growth hormone, cause growth or improvement in the cell types that are available. And also in the way the cell is able to use energy. So, or to create energy. So these are growth promoting, life promoting peptides, as opposed to break down and destroy peptides. So we know that people are stressed out. They're more likely to have that catabolism. And we can use things like oxytocin or other anabolic steroids to help, or hormones to help with that, peptides to help with that.
So I think it's sad that the word anabolic has become a bad word because of sports doping.
Yes.
But you would no more apologize for putting an addition onto your home. Oh, we added a new bedroom. Oh, but it's not because we needed a new bedroom. It's like anabolism is a good thing. It means the body is building. It's building itself. It's repairing itself. But we have to apologize for using that word because it developed this negative connotation. Isn't it sad?
I love that awareness. Thank you for that. Yes, it's true. And it is frustrating because I know, my sport is powerlifting. And so for me, I'm not about getting bigger like a bodybuilder might be, but I am about getting stronger. And what's interesting is most of the research, even in most of the anabolic peptides, does not show that there's an improvement in muscle, what we really see is an improvement in recovery. So because of your improvement in recovery, I've heard you talk before about using your stack post workout. It means that you're able to go back and work out again the same day or the next day versus having to wait 48 hours before you can go back and lift heavy again or do whatever your sport is again. So if you're able to go more often, then you're actually able to do the work. So that's what I really like about most of these. And that's how I think about these anabolic peptides, is because they allow us to do more often what we need to do. So we're able to persist at the activity.
I used to use an analogy, like if you were a brick mason and you build a wall and you have to wait 2 days for the concrete to dry before you can continue to build. But now all of a sudden somebody brings in a big fan and they blow air on the wall and it dries faster. Oh, so we can build walls faster. That's really what you're talking about here. We're talking about speeding up the recovery process so you can get back in. And that does allow you to get bigger and stronger, because if 5 workouts build X of strength, then doing those 5 workouts in a shorter period of time builds that same X. That means in the original time, you can protract that out and you can actually get stronger and stronger. And it's really, and again, we shouldn't even have to discuss this, but the medical orthodoxy frowns on the word anything anabolic. It's, it's dangerous. And that's not true. We're anabolic for the first 20 years of our lives. That's why we start out this big in our mother and then we end up this big. That's anabolism at work. So let's talk about some of the peptides that you focus on in your book. Talk about them.
So probably there's several that are really useful. One of my favorites is larazotide. This is an oral peptide. I really have found it's super helpful, especially in women. If we're talking about the women who are a mom, an executive at a company, and the adult child of an aging parent. So you have all of these different hats that you wear. And so your stress level is pretty high. We know that tight junctions in the intestines, one of the things that destroys that besides gluten is stress or high cortisol levels. And so that tight junction becomes loose, and now it allows the entry of things that aren't supposed to get into the body, which then triggers the immune response, and all kinds of whole body reactions occur. So if with something like larazotide, which is a tight junction reestablisher, if we can use something like its chemical name is AT1001. If we can use something like AT1001 to reestablish those tight junctions, we can decrease whole body inflammation, even in the face of some stressors. Now, it's in phase 2 clinical trials, last I read, for specifically for celiac disease. And I think they're working on modifying the molecule additionally beyond where it was the last time it was in research. So there's a new version of it that's coming out fairly soon, but it is one of the only oral peptides that's available. I do find it very effective, and it's great because you can use it just once a day in many people who don't actually have full-on celiac disease. You can use it once a day before their first meal and find that they get a lot of improvement in their whole body inflammation. And in even things like that nighttime waking up at 2 o'clock in the morning with that cortisol surge, we can find that those people are able to get some improvement even in that, just because we're decreasing their inflammation, their whole body inflammation.
Would that be a go-to peptide for anybody displaying some sort of autoimmune disorder? Because we understand now that autoimmunity is things that should stay in the digestive tract, getting into the bloodstream, being identified as a bad actor by the immune system. The immune system goes after it, but at the same time it goes, oh, that looks strangely like the meniscus in my knee. So the immune system goes, well, there's some over there. Let's go for that. So people need to understand that autoimmunity is the natural response of the immune system, but there becomes innocent bystanders that get hurt as well. Would you go to that immediately if somebody comes in and says, I've got an immune disorder?
It's definitely in my top list of autoimmune disease fighting. And I would consider, as you just suggested, definitely I would consider osteoarthritis as an autoimmune. This is not this is an inflammatory state. It's not just because of trauma. The trauma is usually the second hit that hits there's a whole condition called an inflammasome that happens inside the cells. And so those cells become taxed by the stressor, but it's a 2-hit requirement to begin that inflammatory process that occurs as osteoarthritis. And usually the first hit is something in the intestines. We usually have some sort of inflammatory process. It could be something as simple as as a colonoscopy prep, or 3 days of antibiotics that changes your microbiome. And now we end up with an inflammatory state in the intestine that creates this whole setup. So you have some sort of minor trauma running, wearing high heels or wedges, and turning your ankle. And now you have a whole inflammatory process that looks like osteoarthritis. So we have to keep in mind this is an inflammatory process, and that it's occurring not only in that joint, but everywhere else as well.
And I find the interesting that when we used to believe that osteoarthritis, which usually had an obesity correlate, was blamed on the mechanical loading of joints, until you started to say to yourself, well, why does that obese person get arthritis in their fingers? They're not walking on their fingers, and why do they get it in their neck? And that was like one of the earliest observations that I made. And then when the research started coming out that basically said osteoarthritis is like rheumatoid arthritis, it's just moving a lot slower. That's really what it is. It's fascinating. Do you have a hard time convincing even your peers that osteoarthritis has an autoimmune component?
I would say not my peers, but things like orthopedic surgeons, those are difficult to convince. Physical therapists, those are sometimes difficult to convince of that state. That we have to be looking at the inflammatory state of the whole body when they show up with their osteoarthritic knee. You can't just focus on the knee and turn your head away. You got to look at the whole body. What else is happening? What do their arteries look like? This is a person who's at risk for heart disease and dementia because this is an inflammatory process. It just happens in this particular person to be focused on their knee. Yes,
and a lot of people don't understand that, but some of the new research that Dr. Sean Baker is releasing about the hyper-responders having 600 LDL and 0 plaque, we're starting to understand, which is bad for the pharmaceutical industry, because the pharmaceutical industry wants to find one thing that they can sell to a population. And now we're starting to learn that there's variables in this whole lipid model. Talk about so that's good for the gut. And I have to believe that getting the gut straight first is the critical first step in any progress. What comes next?
Yep. So, and getting the whole body inflammation down. So I'll use other things too. We'll use some thymosin. I love using the thymosin, especially if we're talking about some osteoarthritis. It is, I've found so helpful to use any of these anti-inflammatory things, and then to be able to treat the joint itself. So even meniscus tears, meniscus injuries, even things like avascular necrosis, we're able to treat those things without people having to go to surgery. And we know that due to some fairly recent research, that patients who undergo arthroscopy for a meniscus injury or some sort of soft tissue injury inside the joint, we know that those patients end up with osteoarthritis as an outcome. And so that's because we're not treating that underlying. So one of the things we do at our office is treat them with things like injectable BPC. There is a human study using injectable BPC. There is Dr. Lee, I'll put that out. And then there's some interesting research using liraglutide injectable into the knee. And then using, of course, growth hormone and growth hormone secretagogues, not secretagogues, but growth hormone and fragments of growth hormone into the joints themselves for treatment of those kinds of things. And we've had some really great outcomes with treating people with the thymosin and the growth hormone and growth hormone fragments in injecting in joints and tendons.
So I'm going to say something that I've said on the show numerous times, and I've also said it on Mark Bell's show, which will be released in 3 weeks. When I was out in Vegas for the gun show, I stopped in Sacramento and I got an interview on his fantastic podcast. And I'm waiting for someone, since pigs resemble humans biologically, a lot of people don't realize this. And that's why we use porcine thyroid, desiccated porcine thyroid, armor thyroid, and natrithroid. They all come from pig thyroid. I'm waiting for someone to realize that sweetbreads, which is an old world food, I used to eat lamb sweetbreads when I was a kid. I loved them. The pig has a thymus gland, and they call it sweetbreads. If we could desiccate that and get that into capsules, people could take the entire array of thymic hormones day in and day out. And I've said it so many times, like I have no interest in being in the supplement business. I'm in the gun business now. I'm in a different place I really like, but I'm waiting for someone to reach out to a large producer like White Oak Pastures, and getting them to keep the thymus glands and then sending to wherever you can send them that would allow you to desiccate them in a controlled environment and encapsulate them. I predict that would be a huge supplement.
That's a great idea.
And healthy too, very healthy.
So I'm sure you're familiar with the bioregulators that our precious Dr. Vladimir took, and especially the thymus gland. Those are all, of course, bovine, not porcine. So there is a little bit of difference in genetics, but that may be something you could think about. But I like the White Oak Pastures option. That's a great idea.
Yeah, I mean that would be a great supplement. I'm waiting for. Too bad Liver King is gone. I can sign for that if you need me to. I'm on the air, but I'll be happy to sign for it. Which office? Go up, make a left. The first door on the left. Sorry about that. It's a fatality of leaving my door open when people come through the hole. But this room is so small and coated in foam. I feel like I need to leave it open. So let's go further down this path. So what else are women looking for that you can provide? And let me put this up real quick. So if you would like to get a free copy of chapter or chapters, you can go to vinemedical.com/counterclockwise. vinemedical.com/counterclockwise to get and the book will be out in March, you said?
March 4th.
March 4th. Okay. Very valuable book. And the exploration and deeper knowledge that we develop with peptides as time goes on is very, very important because we're still learning so much about what these peptides are capable of doing. So where else do we look as far as peptide therapies when people are wanting to regain their health and vitality?
And you're exactly right. There are over 80 approved worldwide that are used by pharmaceutical companies. This is one of the growing areas of research, and most of the new drugs that are coming out are some version of a peptide. So it's very interesting. I think one of the ones that I really am fascinated by is VIP, not only for energy, but also for its anti-inflammatory benefits. And so one of the places where I commonly will use this in my patients is for if they're traveling overseas. We use this VIP in the morning. It's a natural reset for your circadian rhythm. And it raises NAD. So you can't use it too close to bedtime. You have to make sure you're using it in the morning. So I'll tell people you can use up to 4 sprays, but you got to use it all before noon so that they'll be getting, they'll get a lot of intestinal motility. So a lot of women will experience slowing of their intestinal tract, either from using some of the weight loss medications or from just in travel in general, from being nervous with travel in general. And so we see them to be able to move their bowels more easily when they're using VIP as well. So I like using that for travel.
What does VIP stand for?
Vasoactive intestinal peptide.
Interesting.
Yeah.
So as we age, one of the phenomenons that occurs, especially if we're not somebody who is very active, and it's hard to be active when you have a job and patience, is a reduction in vascular density throughout the body. The peripheral, hands, legs, we start to see blood flow reduced. And this is not from clots or blockages, it's just a natural reduction in vascular density. Does VIP help with that, or is it just strictly to the gut?
Oh no, definitely helps with that. I think that this is one of the better peptides for inflammation. That's kind of an unsung hero. It's one of my favorites. We use it in our practice. Also sees a lot of heavy diseased patients like mold and Lyme, chronic inflammatory response, and this is one of the things we use to begin to get them out of that state. So yes, we're going to see a lot of decrease in that endothelial inflammation that can occur that causes a lot of the atherosclerotic disease.
And when you talked about vascular necrosis, does that speak to this same phenomenon where we have a retraction of blood flow to tissue?
It's a slightly different thing because avascular necrosis of the hip is a bone, but yes, I mean, it is retraction of the vessels from the hip. So this is one of the things we would use in that case. That patient, we used a fragment of growth hormone. We used BPC and thymosin beta and GHK. We used a big stack of things for her to get her recovered, and she's back to doing CrossFit now. So
that's the interesting thing. I'm sure that because you are a power lifter yourself, that you inspire your patients to apply resistance training and get stronger, and they fare better. I bet if you take that out of the picture, the peptide may not provide as much relief, but when you start using the body the way it was intended to be used, the body pays attention to the areas that need to be fixed.
Right. At the time when we saw her, we stopped her from doing much activity at first because she was at a point where the avascular necrosis was so severe, she would have fractured had we persisted, then she would have required to go to surgical replacement. And so we had her stop for a few weeks. And yet she continued, despite us saying don't lift heavy, she continued walking and doing some upper body lifting the entire time. So she's getting that myokine infusion every time she does that heavy lifting. So her body is in a healing mode, healing and recovery mode, even though she was not doing her heavy lifting from before.
Right. Do you remember the show I did with Dr. Dunn many years? I mean, probably 2010, 2011, where he was injecting growth hormone, intra-articular growth hormone injections 3 weeks in a row. And people were regrowing the actual cartilage, meniscus, soft tissue in their knees. Why isn't that done more often? Is it because growth hormone is, what are you using your growth hormone for?
I think that's the case. You know, I have a patient who lived in Illinois, and she had Sheehan syndrome, which is a pregnancy-related death of the pituitary gland, and so she was not producing any growth hormone at all. So when I sent a prescription to her pharmacy for growth hormone, the pharmacist looked on my website and saw the word anti-aging on my website and refused to fill the prescription. So that may be it. Keep in mind also, there are over 100 iterations of growth hormone in the body naturally. And what's available commercially is one. So you're probably not getting the same benefit you would get as if you were using a growth hormone that was a combination of multiple versions of it.
Or a good secretagogue.
That's why I like the secretagogues.
Yeah. The ghrelin to suppress somatostatin, and then a releasing hormone, CJC. I hate calling it CJC without DAC because Konjac, when they created CJC 1295, it had the drug affinity complex to keep it alive for 7 days in the blood. So now there's CJC with and without DAC. No, CJC without DAC is called growth factor releasing hormone 1 through 29. It's like it's just a silliness that the secondary markets have created. But yeah, a good secretagogue combo should do everything you need, right?
Right. And I don't know that I would inject that into the joint. You could use the fragment. You could use AOD. And there's a new, with the new FDA regulations on the compounding pharmacies coming down, there is a new AOD 9601.
Oh, really? Really? Oh, yes. Why would we move away from what we've had? I mean, AOD 9604 used to be called fragment 174 to 191 or something like that, right? That's what it used to be. Do you remember what it was?
Yes, the difference I think is that I think that AOD, as opposed to frag, is actually it's formed. The protein is reshaped so that it's bound by a cysteine-cysteine bond and disulfide bond, and it is that way it's less able to be broken down by the enzymes that break down growth hormone, which I believe is DPP4.
Yeah.
So frag and AOD are slightly different.
So you address in your book, you address peptides that will afford people to live longer, healthier, more vibrant lives. What do you do about the brain? Because that's a big issue in today's population.
It really is. So we use we use cerebrolysin. We use dihexa. Dihexa is oral, which is really convenient, and those are really, obviously, like you said before, we start with the gut. We decrease inflammation in the whole body. We get people training as quickly as we can. And so all of those are the stacks that are involved, making sure that they're present, making sure that they have all the things they need. I'm almost always going to start them with some sort of growth hormone secretagogue, as long as their levels are through the roof. To begin with, the IGF-1 isn't through the roof to begin with. I'm going to probably start almost everyone, because everyone I'm treating is at least 50 years old. So there's very few that have normal growth hormone levels at that age. We know that declines with aging. So we'll start with some sort of secretagogue and then decrease their inflammation. And then specifically for the brain, we'll use things like the dihexa and cerebrolysin. I really love thymosin beta. There's so much research, particularly in animals, with using it for traumatic brain injury, et cetera, for helping to decrease the stress and strain that occurs on the brain, the inflammatory process that occurs in the brain. And then some of the smaller peptides like L-carnosine, that's a 2 amino acid peptide that I think is really also very helpful for the for cognition and for helping with chelation of some copper inflammatory copper.
Right. There was a study that was just published. I haven't read it yet, but it looks at men and women and the relationship between zinc and copper and inflammation. Adele Musa posted something about it, but I haven't had a chance to look at it. What about melanotan-2? Melanotan-2, I'm a fan of intranasal microdoses of melanotan-2. Melanotan-2 seems to suppress inflammation as well in the body. And if you take a low enough dose, you don't turn brown overnight, but you do start to get a nice patina color. What about melanotan-2? Do you include that in your therapy?
Exactly. Yes. And I love that for its anti-inflammatory effect. It has that general, but think about this. I always think about it as the vacation peptide, because we'll start using it 2 weeks before you go on vacation, and then you'll use it every single day. And then it's got the anti-inflammatory effects. It's got the libido effects. And so why wouldn't, and then the tanning effects. So you get this great pre-trip and then during your trip peptide that's going to kind of hit all the concerns that you might run into. And then of course we use that in our very inflamed patients for that purpose. One of the interesting things is this can be a great add-on to if you're having a slow response to some of the other peptides for weight loss. You can use melanotan-2 in helping patients in addition to their GLP-1s, for example, or their GIP. There's several new ones that are coming out. That actually a recurrence of the old amylin is getting ready to come out there. That's in phase 2 trials too, for weight loss. But I really like using melanotan-2 in that case. You're going to get, we know that about 6% of obese patients have a deficiency in melanocortin, or alpha-linocyte stimulating hormone. And so you can get that benefit for those patients. We also will use it in our SIRS or chronic inflammatory patients for their decreasing their inflammation.
So I read a study that people with higher iron levels, so we understand iron overload. That's one excessive thing. But we know that people with very low iron levels don't fare as well. And I'm trying to repiece the study in my mind. But what I got away from out of the study was that in million years of evolution, iron only was obtained when we killed an animal and ate it, because plant forms of iron aren't really that good for us to absorb. But direct sunlight improves the ability of our bodies to extract iron from plants, which would have been an evolutionary advantage. What happened, Suzanne? Where'd you go? Suzanne, there you are. Okay. It would have been an evolutionary advantage. And melanotin, too, I suspect, increases the ability to absorb iron. Any thoughts on that?
Yeah,
Suzanne,
so of course
I think
you have to have that for mitochondrial function. So let me see if I can get the camera.
We're having a little problem keeping you on.
Can you hear me now? So I wonder if you have, if it's, let's try this.
There you are. There you are.
I wonder if it's because because of how it works on melanocortin receptors in the intestines. And, that's how we're going to improve mitochondrial function with melanotan.
Interesting. That's very, very interesting. Let me put this link up again real quick. So for people who want to read a sample chapter or chapters, go to vinemedical.com/counterclockwise to get that. Now, the book is going to be released in March. And where will people obtain it?
Either from Amazon, or we'll have a link to it directly on our website, which is vinemedical.com.
Now, you actually lecture, you tour the anti-aging events, and you speak about peptides. Doctors, mainstream doctors, are they more interested nowadays? Because for a long time, they didn't really pay attention to peptides. But now I guess more and more are. Are you seeing a bigger awareness amongst just mainstream doctors?
Well, there were something like 6,000 people at the A4M event in Las Vegas in the fall. I know we moved the peptide segment over to a different, it's going to be in March 1st. The peptide segment is going to be March 1st. But I think there is a growing interest. Because of the presence of CGRP inhibitors for migraines and of the GLP-1 GIPs for obesity and diabetes. And so I think there is a growing interest. I think a few people have been a little bit shied away because of the recent FDA things, but we have to realize that none of these are being FDA removed because of significant serious adverse effects. The removal, there's lots of reasons that you could probably speak to, Carl, and I can speculate why. But but we have to realize that they are not being removed.
To dovetail into that, what is a peptoid? Have you heard of peptoids? The pharmaceutical industry. Yeah, so the pharmaceutical industry has been working on peptoids. They are synthetic activators of peptides. You could call them precursors. Sure. So the pharmaceutical industry is very interested in capitalizing on the peptide industry, but they really can't really patent a peptide that already exists naturally in the body. Now, there are some people who are extracting certain portions of the domain of a peptide, and like sabinatide, ARA290, we have a company that actually patented that because they extracted it from another peptide. But the reality is that the pharmaceutical industry they don't know how to capitalize on peptides right now, because 99% of the effective ones are naturally occurring. So they're coming out with something called peptoids, Peptoids. And what peptoids are variations of drugs that stimulate the production of the native peptide. And that makes you say, well, why would I want to do that when I could just take the actual peptide? Well, they can't make money on that. So and I believe that the FDA is acting in the best interest of the pharmaceutical industry, because they really don't understand how to get their hands around this. Now, I know I'm not asking you to speak to that, I'm just throwing that out there because I know that you are a good doctor, and you have to kind of stay in the lane. But this is my observation. I really think the pharmaceutical industry is trying to figure out how can they take a hold of the peptide industry.
Because they realize that they are so effective. That's one of the things we're running into, is they really are very effective. So because they aren't able to be produced, and again, this is my speculation, but because they aren't able to produce or to make money off of them or patent them, they have to figure out a different way to do it. I think I read recently about them doing a peptide for thymosin alpha-1.
Yeah, right. Mm-hmm. Yeah. So they take thymosin alpha-1 out of the mix. You can't get it. And then they create a drug that basically makes your body make thymosin alpha-1. It's so silly. And I hope most people realize how silly it is. So tell some stories. Can you tell some stories about patients specifically that have been working with the types of protocols delineated in this book and the outcomes? Can you talk about that?
I'm having a little trouble hearing you, but I think you said, tell us about some stories that had some great outcomes.
Yes.
Okay. So probably one of my favorites is a patient who had PCOS. And there's some really interesting research. I think we're underestimating the potential impact of these GLP-1 agonists. There's so much research. They were originally studied, used in patients with neurodegenerative disease like Parkinson and Alzheimer's. And so it's pretty exciting to look back and see all that's available there. There's also quite a bit of research using them in treating things like PCOS. And so for patients who have infertility, this is one of the things we could use to treat. So this woman came to see me. She's probably 33, 34, and she had PCOS for many years with lots of pain and large cysts on her ovaries. And we treated her. She had been on a metformin for quite a while, oral metformin, with lots of GI side effects, and fatigue and weight gain and just feeling terrible. And so she was one. We put her on a growth hormone secretagogue. We put her on a GLP-1, and she had a really great outcome. She has just gotten married, so she hasn't gotten pregnant yet, but we're excited about the possibility of her being able to do that. What we are seeing is changes in her ovarian function, changes in the number of if you understand about fertility, one of the things we want is one dominant follicle to come up in the growth of the embryo. And so she was having multiple follicles come mature, but none of them would actually go to their full potential. So she would be unable to get pregnant. And lots of women deal with this situation. There also are people who have a condition called endometriosis, and endometriosis is the implantation of parts of the endometrial lining onto other organs in the body. One of the ways that they do that is by a chemical called MMP9, or metallomatrix protein 9. And this will cause her drill a hole into the intestinal wall or the bladder. And we can use some peptides to reverse that or decrease that, as well as decreasing just general inflammation. So we're treating some of these other female predominant disease states with peptides as well.
So you and I talked off the air about my postulation, and you said you have used it this way: the use of a ghrelin agonist to potentially reverse the paralysis of the digestive muscles that is seen in just a small number of people who use these GLP-1 agonists, these long-term active GLPs. You take it once a week. Do you think there's a place to actually use a ghrelin agonist while using the GLP-1 so that you can actually have the desire to eat a good meal, like post-workout, right? You train and you should have a nice high-protein meal, but you're not hungry. Could you use 100 micrograms of a ghrelin agonist to bring on hunger just for that one bout, eat it, and then the GLP-1 agonist kicks back in and you don't have a lot of hunger the rest of the day?
That's exactly right. That's exactly right. So that's how we prescribe them for our patients, is using them around that time. So I think it would do several things, or my experience is it does several things. Women talk a lot about the Ozempic face, and it's they get, so there's falling of their face because they're losing a lot of the subcutaneous fat. And so if you're replacing that using the growth hormone secretagogues, you're going to be producing a lot more collagen. So using GHK, using growth hormone secretagogues, you're going to get that effect as well. And then instead of losing that, getting that sort of sagging skin look that a lot of women get who use the GLP-1s, they'll be hopefully building muscle. So you'll have them not become sarcopenic and lose so much muscle mass. That's one of the ways. So we're sort of hitting several different of the negative consequences or potential negative consequences. Obviously, if you're doing resistance exercise and you're eating enough protein, then you're gonna have a way better outcome with the GLP-1s anyway. But if you add on top of that a growth hormone secretagogue, we really can see some great effects. And most of the time, we do not see an overproduction of growth hormone when you're using a growth hormone secretagogue, as opposed to using growth hormone itself.
Right. Now let's stick with that for a second. So I've been thinking about doing intranasal GHRP6 and CJC1295 as opposed to injecting it, because my thought is I'm injecting it to influence my pituitary. Why not just spray it in my nose and let it go right to my pituitary and create that pulse? Has there been any studies on intranasal secretagogues being more effective in lower doses than injected?
So it's interesting that you asked that. Over the age of about 60, the research shows that cribriform plate really becomes more solid and doesn't have the access. That's the access point inside the nose, where we can get to the brain and the pituitary. That cribriform plate becomes more solid, so it doesn't really have as much. I think that's going to be individual dependent. You're going to find if you're someone like you who's been optimized for years, you're probably not going to have that solidification of your cribriform plate like some people over 65 would. There's a young 65 and there's an old 65.
Yeah, right.
So I think there are several that are going to be available. VIP can be used intranasally. The CMAC and C-Lank, of course, are available intranasally. I'm interested to see. I haven't used the
So let's plug the book one more time. You can get a free chapters by going to vinemedical.com counterclockwise. The book will be available in March. Is this the first book you've written, Dr. Ferree? I don't know if she can hear me or not. Can you hear me? Suzanne, can you hear me? No, we're having a connection problem. Our camera drops out periodically. Can you not hear me, Suzanne? No? I know she can see me. She's blinking. Okay, I think we're going to have to end the show now because we have a really bad internet connection here. Suzanne, I don't know if you can hear me or not. I'm guessing you can't. Okay, we're gonna have to end the show. She's sitting there like a saint, trying to keep things going. But Can you hear me, Suzanne? Can you hear me?
Yes.
Okay, I lost you there for a while. I guess we have a bad internet connection. Is this the first time you've written a book?
It is.
Was it harder than you anticipated?
It was. We also ran into some speed bumps a little bit. We started back with Scribe, and I don't know if you know what happened with Scribe, but they went out of business. We went up to, we started with them in a year ago, February, and the book was already in the works. All the copy was written, everything was ready. We were starting to go into editing. And then Scribe, I just got an email from them saying that they had closed their doors. They were all gone. So
that's terrible.
It was terrible. So now I had to scramble to find a new publisher and a publicist and a marketer. And so that's been the last 6 months, has been trying to reclaim what was already existing. So we just started back editing again, and it's almost ready. It'll be out like I said, March 4th.
Will you write another book after this? Have you had thoughts like of while you were writing this book, there are other things that you'd like to expand upon in a book?
Definitely. So the next thing I think I will write, we have added neural therapy to our practice. I don't know how familiar you are with neural therapy, but there really isn't a lot out there about it. And so I think that's the next thing we'll add. It has been dramatic in how it helps. I was going to ask you about if you'd ever had neural therapy for your neuropathy. We've had some really amazing outcomes in using it.
Tell me more about it.
What patients with ADHD.
What is it?
It's
what is
procaine injections. Procaine injections. It's about a century old. It's been used for many, many years, primarily in Germany and South America. And we use the procaine injections with a little bit of bicarb. You can either do it, we do it sometimes IV for our patients. We'll do it but generally we do it in the skin as a subdermal injection. And it gets immediately absorbed by the nerve. And because people will start to say after 2 milliliters, they'll say, wow, I kind of feel that in my head. They get a sense of euphoria as well. And so what's interesting is we get improvement in a lot of pain syndromes by using this either around the area of injury, over a scar line. We get a lot of fascial release by using procaine. Procaine increases blood flow and restores the way that cells, the electrical conduction of the cell. So that's kind of exciting to use as a therapy for patients. We get some pretty good results.
Yeah,
We've actually converted some.
Yeah, that sounds interesting. So I'd have to come to your clinic to get a treatment, right?
Yes, we're doing a conference for doctors on February 23rd. So that's also available if a provider wants to learn more about how to do that.
I have a doctor friend I'm going to tell about it. I'll tell him to get in touch with your office. The guy who does my intravenous
it's really great. It's been very
this will be right up his alley.
Oh yeah.
One more time for those of you who are tuning in late, vinemedical.com/counterclockwise to get sample chapters of the book. The book will be out in March, and you'll be able to get it at Amazon. You said Amazon.com, right? Is where you're going to put it up?
Yep.
Okay, there you go.
Exactly.
Great stuff, Suanne. Thank you so much for being on the show today.
Thank you, Carl, for doing the show. I really appreciate you.
Okay, and we'll see everybody again. I got a secret show we're working on right now with Dr. Sean Baker. Let me put this up so people can see what the book looks like. I got a secret show we're working on with Dr. Sean Baker. I'm just waiting for him to get in touch with me. But I sent Dr. Sean Baker an epigenetic age assessment test, and he's going to come on the show to break the news on how old he is chronologically versus biologically. I'm just waiting for the results to come back. That should be a fun show. All right, look, who knows? Keep your eye out. Yeah, I know. More shows will be popping up. And don't forget, gunleash.com. Gunleash.com. We're still looking for a few more investors. We came back from the SHOT Show. Every single gun manufacturer I met with is interested in working with me and solving this problem with lost and stolen handguns in America. Gunleash.com. Check it out. Okay, see you later, everybody. Bye.
Thanks, Carl.
Bye.